Hello, everyone. We are going to talk about CPAP. And remember, this is continuous positive airway pressure. It's one of those special oxygen devices that we may place on a patient to help them with their respiratory distress. And we'll talk about the specific types. We're going to talk all about CPAP in this lecture. So, continuous positive airway pressure. It's continuous and it's positive pressure. So let's talk about when you can, when you should, indications, when you should do so, right? We have our happy stock photo lady here. She's got a nice smile on. She's got two big thumbs up. She's like, yeah, you can go ahead and give CPAP for these things for respiratory distress, right? That's the main thing that we're going to be using this for. And in that category specifically, CPAP is great for bronchospasm and pulmonary edema. It's not the only two things that it's helpful for, but in the categories we're going to talk about today and in the most use is in these two categories. And ultimately, what our main goal, one of the main goals of CPAP is this alveolar recruitment. So this is where we're going to take alveoli that are not useful right now or not working in terms of gas exchange, and we're going to make them useful again. We're going to recruit them and get them to be functional alveoli again, able to participate in that gas exchange. So we'll talk more about alveolar recruitment in a bit. But let's explore some of the indications a little bit further, just to review bronchospasm. Remember, this is sort of that reactive airway disease, so that bronchial constriction. So we're talking about that asthma, COPD. Anaphylaxis does cause this, but just keep in mind that we have better ways of handling the bronchoconstriction in terms of anaphylaxis. Mainly the EpiPen, right, is going to reverse that. So CPAP is not going to be useful in that sense. You would rather use Epi or some other things that will be directly fixing the problem of anaphylaxis. So when we talk about this bronchospasm, let's really focus in on these reactive airway diseases and especially asthma and COPD, among a few others. So just as a sort of reminder to everyone, we have our normal airways, right? Nice and open. Airflow in and out of the alveoli is completely unimpeded. Great. Reactive airway disease. You are diagnosed asthmatic. Just remember, we talked about this. You have that constant inflammation, which is constantly creating this narrowed passageway into the alveoli. That's at baseline. That's the way it always is. But then you can have an exacerbation. And by this, we mean like an episode or an attack. And this is where you have these already inflamed and sort of narrowed airways with bronchospasm or that constriction of the smooth muscle that even further narrows that tubing. And we talked about this during respiratory. The problem is now getting the air out. The problem is getting the air out of such a narrow tube because the pressures are so low. So air trapping is the result of this. The air just gets trapped inside of these alveoli and can't escape through these narrowed bronchioles. Now, when we look at this sort of take a step back and see the bigger picture here, what we're seeing is that this alveoli may be right here, and that might be air trapped. Okay, well, we have like several billion other alveoli in our lungs that will participate in gas exchange. One of them not functioning is really not that big of an issue. However, the problem starts to become where you have we have a bunch of them right there, maybe air trapping there, maybe air trapping all over these alveoli, and then suddenly you wind up in a place where an entire section of the lung is dead space. Those alveoli do nothing. They're useless in this entire area. So now you might be saying, well, we have all the rest of this lung tissue. They're all performing gas exchange, so this isn't that big of a deal. But what happens when they're getting sicker and sicker and more parts of their lungs? And I'm doing this just as representative. It could be down here, it could be here, it could be anywhere, whatever. But the point is, the more, that this exacerbation, this episode progresses without intervention, the more areas of air trapping and dead space that are going to occur. And the worse their oxygen levels are going to be, the worse their breathing is going to be. So remember, that's bronchospasm in a nutshell. And we'll talk about the indication of pulmonary edema. Remember, this is fluid in the lungs. And most commonly, we associate this with sort of heart failure, specifically left-sided heart failure, right? Left ventricle. But this can be from infections. This can be from trauma and altitude. We see it mostly with our heart failure patients. Now, this can come in two different flavors. In a sense, you can have that fluid filling up the actual alveoli itself, and that's a problem. You can also have it where it's sort of the fluid is in the spaces between alveoli and it's kind of surrounding them. You can, by the way, have a combination of both, that this isn't a one or the other sort of thing. This could also be full, and this one could have fluid around it as well. And we're going to sort of see in a little bit the problems, but basically, you can't really get oxygen that's going to diffuse and pass through this fluid very well into your vasculature. And the same thing, CO2 has a hard time getting through all this water, this fluid, to get out of the body. And here we have that same problem where it's blocking that crossing. However, we have something else that occurs. This fluid is going to push in and narrow these tubes, physically kind of squeeze in and narrow your bronchiole. And that's going to create that air trapping sort of dead space, unfunctional alveoli on both levels, fluid and constriction. So these are the problems that can occur with pulmonary edema that's going to, again, block that oxygen. And when we look, take a step back again and look at the lungs, the sicker they are without intervention, the more and more lung tissue is going to be obstructed and affected by this fluid. And remember, it starts from the bottom and works its way up because of gravity. And it will start literally coming up their large airways into their trachea and out of their mouth eventually. This is a very sick patient. There's no real tissues of their lungs that are participating in gas exchange. Maybe these little areas up here. It's very little for what their body needs.